thyroid nodules are very common and are usually, their management usually relies on cytology. And there are several new tests now commercialized that search for specific differences at the molecular level to aid in the differentiation of those that have indeterminate cytology, which are relatively frequent. The performance of these tests is known to vary widely among centers because the prevalence of malignancy is very different from one center to another. And so the ATA has recognized that in every center where these tests are going to be used, the prevalence of malignancy in these indeterminate categories of thyroid cytology needs to be assessed. However, these categories are very heterogeneous, and we wonder whether we should treat all these nodules in these categories the same, as having the same prevalence of malignancy, and therefore if we should interpret the results of these tests for all the nodules in the same way. And so we basically review our experience in 271 nodules with indeterminate cytology, and found that we should categorize them into 4 groups: nodules with nuclear atypia, nodules that were mainly composed of follicular cells and therefore were suspicious for a follicular cell lesion or neoplasm, nodules that were composed mainly of Hartel cells and therefore were suspicious for a Hartel cell lesion or neoplasm, and also other nodules. And we found out that those with nuclear atypia had a much higher prevalence of malignancy than any other nodules, 62% versus 17%.